Okay, our last formal speaker today before we have the breakouts is Monica Slavin. And Monica is professor of medicine. She is in Melbourne, Australia, at the University of Melbourne. She is division director at the University of Melbourne and involved with Peter MacCallum Cancer Center and the Royal Melbourne Hospital. So Monica is going to talk to us about prophylaxis, preemptive therapy, and empiric therapy. And we'll have a 10-minute discussion, and then after that we will go into our breakout sessions. Monica, thank you for joining us. I don't even want to ask you what time it is there.
Don't ask, Peter. Thank you very much for the invitation and for allowing me to get up at 5 o'clock in the morning. Well, I'm very thrilled to be here.
You always said you were an early riser. You always said
okay. So I'm really happy to be here today. And this topic is an interesting one. And to focus my talk, I'm really going to focus on the hematology setting. Although we're talking about antifungal prophylaxis, preemptive and empiric therapy, it's not that clear-cut for clinicians. We're dealing with the context of our patients often being on mold-active antifungal prophylaxis, the reality that we're seeing more mixed infections, infections with aspergillus and other organisms, the emerging mold infections that we're seeing particularly in patients on antifungal prophylaxis, and the advent of immunotherapies now in our hematology setting, whereby patients, many and frequently may have fever, but not neutropenia. And where does that leave us in trying to decide whether to use empiric antifungal therapy? So it's a murky world, and I'm going to try and discuss some of these issues today. These are my disclosures. So just going back to really set the scene and talk about what we mean by preemptive prophylaxis and empiric. I think we know that with prophylaxis, we're giving these drugs to everybody at risk. We're often using a mold active agent, or if we think the risk is only for Candida, we're using an agent like fluconazole. There we go. That's its ordinary size. Is that okay?
I think that's okay.
Yeah, I'm so sorry. I'm not sure what the problem is. No problem. But anyway, let's talk about prophylaxis, empiric therapy, and preemptive therapy. So I'm really talking about some of the caveats in these approaches. And so I think really with prophylaxis, one of the key factors we need to know is our risk profile of our patients, because we only want to give this approach to our highest risk patients. And of course, we do have problems when we use this approach in then using serum galactomannan, where we'll have reduced sensitivity. And we are seeing emergence of non-aspergillus molds in this setting as well. Turning to empirical therapy, it's traditionally been indicated for patients with persistent or recurrent fever during febrile neutropenia. And so that is really a limitation in that fever is not sensitive or specific for invasive fungal disease. And particularly in the era of immunotherapies, fever is very common and our patients are not neutropenic often. So we don't really have a sensitive way to determine who needs empiric antifungal therapy in this group of patients. And of course, we still need diagnostics because it's not really feasible in today's world to treat everybody who requires empiric antifungal therapy with a prolonged course of antifungal therapy. Well, turning to preemptive, this is the therapy that's driven by diagnostic tests, traditionally Aspergillus galactomannan and PCR, and use of mold active agent if these tests are positive. Of course, this is more difficult to implement. You really need to identify your high-risk group. You need expertise in interpreting the tests and access to timely test results. So again, caveats around how we might implement this kind of approach. Looking at antifungal usage, of course, with prophylaxis, it's going to be 100% of patients. Empirical therapy studies show us that it's used in 30 to 70% of patients with high-risk hematologic malignancies. And then preemptive therapy, antifungal use is around 20%. So you can see a reduction in antifungal use across these categories. And this parallel, of course, cost, toxicity, and drug-drug interactions. But the opposite applies to the logistical challenge. Obviously, it's very much easier to apply prophylaxis to our patients than to apply preemptive therapy, where we need all those prerequisites about expertise and monitoring and turnaround time. So I'm just going to look at a couple of the studies that relate to antifungal therapy and looking at the different strategies. So I want to talk a little bit about prophylaxis studies. And the real point of this slide is not to compare studies. These are very different patient populations. These studies were conducted at very different time frames. And the approaches, some of them have used galactomannan as well as empiric therapy, for example, in the Cornelli prophylaxis study. And some of them have only used empiric therapy without screening in the Mark's prophylaxis study. So these studies are not really comparable in their design or nor their patient population, but really just to show the findings that we see and the broad trends that we see with these studies. Of course, with prophylaxis, the rates of fungal disease are low and increased numbers of fungal diseases in the empiric therapy approach and the preemptive therapy approach. I would like to talk a little bit about one of the newer studies, which has only been presented in abstract form at the moment by Johan Martens. But this is a very interesting study run by the Europeans. It's a large study, enrolled about 550 patients, where they randomised patients to receive either empiric antifungal therapy, no monitoring, no galactomannan screening, and empiric therapy as guided by traditional means in these patients with AML and stem cell transplant, versus a preemptive approach where galactomannan was used to monitor the patients. And this study was powered on a survival at 42 days after entry into the study. And what's really interesting about this study, I think, is that they do not see a difference in survival between using an empiric antifungal approach or a preemptive antifungal approach. And this is really interesting because I think, you know, many of us have been turning away from an empiric antifungal approach, more in favour of screening and preemptive therapy. But I think we do need more information about this study because I think knowing that galactomannan was available in all of these centres, it's very feasible that once a patient started empiric antifungal therapy, that they were aggressively investigated and received a rapid diagnosis and targeted therapy. I think this is what we need to look at when this study is published, because at the moment we've just seen these abstract and these very interesting figures here. So turning to these preemptive studies, I've summarised here on this slide some of the findings from several preemptive studies that have been carried out over the last several years using galactomannan alone or galactomannan and PCR to screen high-risk hematology patients and to use that as a guide to when to start antifungal therapy and comparing that to a more empiric-based approach. And what these studies have shown us is that it is safe to withhold empiric antifungal therapy. There's about approximately 50% reduction in the use of empiric antifungal therapy if you are using this screening and preemptive approach. But this is offset, of course, by an increased number of treatment courses, because you will diagnose more courses of invasive fungal infection with the screening approach. They also tell us that we can diagnose aspergillosis earlier by using this kind of preemptive approach. And as I've mentioned, the Martins study does show that there was a non-inferior survival with galactomannan and CT scan guided approach compared to an empiric approach. And I think this is going to be a very interesting study to look at when we get the full details. Looking at how this preemptive approach performs in terms of cost and in terms of overall cost of the strategy, there have been several meta-analyses, and I'm presenting one here done by Francisco Marti's group, where looking at the cost of the antifungals with the pre-diagnosis of invasive fungal disease and after the invasive fungal disease was diagnosed, as well as incorporating the cost of the testing strategies used in these two approaches. You can see that there was a very similar total overall cost, but that the preemptive therapy came out slightly cheaper in this meta-analysis. But of course, this very much depends on the cost of running the tests in your centre. And if it is more expensive, I think this advantage may well be lost. But several studies and several meta-analyses have found this similar finding in terms of cost. So what are the limitations to these approaches? I think I want to talk a little bit about some of the challenges of implementing these kinds of strategies for antifungal use in the real world. And I guess one of the big ones is breakthrough fungal infections and breakthrough invasive aspergillosis. And a very common scenario is that we are treating a patient with mold-active prophylaxis, and the patient develops a breakthrough. They develop pulmonary infiltrates that's suggestive of a mold infection, and we go on to do further testing, often with a bronchoalveolar lavage or a lung biopsy. But while we're doing that, we'll often start empiric treatment with, for example, a lipid formulation of amphotericin B, wondering whether this breakthrough infection is a mold infection, and if it is a mold infection, is it going to be resistant to an azole? So this is a common clinical issue. And what we also often find is that when we do a BAL, for example, and look at Aspergillus galactomannan, we can detect Aspergillus galactomannan, but often do not grow any fungal cultures. And so we're left with the dilemma, is this a mold that this resistant to the mold-active prophylaxis that the patient was receiving? Is it truly Aspergillus? And just for reference, I've put a table from a recent review looking at some of the fungi that have been reported to cause positive galactomannans, and you can see that it's a growing list. And so a positive galactomannan may not always indicate invasive aspergillosis. And interestingly, Nocardia has also been added to this list recently. So there are a lot of dilemmas in this clinical scenario. And do we want to leave our patient on 12 weeks or 6 weeks if we follow Dr. Vasquez's advice, or shorter, of liposomal amphotericin B? And this is the big question. We have not enough information really to determine what to do with this patient. So there are some very nice reviews, and this one by Dr. Leonakis, looking at the rates of breakthrough infection with the different prophylaxis regimens, including the azoles and amphotericin B. And what this really concludes is that the breakthroughs that we see are very much related to the prophylaxis that we're using, the local epidemiology, the patient characteristics, so the stage of their cancer, have they been multiply relapsed, and have they had multiple prior therapies, and what what prophylaxis they're currently receiving. So there's a lot to think about in these cases of mold-active prophylaxis. And I think this slide also gives us some further food for thought in that this study from Duke looked at patients who developed invasive fungal disease on fungal therapy. And interestingly, the number of Aspergillus infections in the breakthrough infections was much smaller than the non-breakthrough. And the variety of other molds was much more extensive. So we really do need accurate diagnosis for breakthrough infection because the possibilities are extensive. Looking at diagnostics, if we wanted to really follow down the preemptive approach, this was a survey done by Susan Seo and her group of solid and hematologic stem cell transplant centres in the US. And they had about 71 responses. And you can see that the beta-glucan, galactomannan, BAL-galactomannan, and fungal PCR, they were available on site in less than 50% of centres. So this white here means they're available on site. The grey means they're a send-out test, and the dotted line means they're not available. So you can see this was published in 2017, so things may have changed in that time, but I think this is a very real-world demonstration of the fact that we have these diagnostic tests, but they're not immediately available to us, even in transplant centres in the developed world. But when we look at Asia, the situation is fairly similar, so it's a global problem. The Asia Fungal Working Group recently did a survey looking at what was available in these countries in Asia. And you can see that while most had access to histopathology and pathology, galactomannan was only available to 60%. And overall, 74% of people in this expert fungal working group used empirical approach and empirical antifungal therapy. Interestingly, only 30% had antifungal stewardship programs in their hospital, and 80% couldn't use their preferred antifungals due to cost. So this really shows the global kind of barriers to adopting probably what we would consider to be best practice in diagnosis, and therefore the limitations of the diagnostic-driven approach in the real world. So in the last few minutes, I want to think about how we can improve antifungal use. And we've talked about in this session the new antifungal drugs, which are very exciting. And we've talked about implementing antifungal stewardship and the way we might do that. But really, these two factors are really going to be limited by what we have available to us in clinical practice. And that means the diagnostics we have, the accurate risk prediction tools we have to look at who is at highest risk and who should be receiving these agents. And of course, although I'm not really going to touch on it in this talk, immune reconstitution, which is really the elephant in the room. We've heard it mentioned already today as one of the key factors in improving our patients' outcome. So talking about the gaps and how we might address them going forwards, I think risk assessment is really critical. It underpins who we give antifungal prophylaxis to, who we consider for empiric antifungal therapy, and also in which patient groups we might look at preemptive therapy. So unless we've got good risk assessment tools, we're really applying these strategies in a bit of a vacuum. So I think one of the things that we have heard in recent times is the focus on potentially identifying genetic risk factors to add to our clinical risk factors. There's a lot of work going on about the microbiome and colonisation and the microbiome and how that might predict invasive fungal disease. And of course, immune profiling may also play a role in identifying our highest risk patients. So I just wanted to put up this very nice study, which shows some elegant work looking at the CARD9 gene defects and how that impacts on invasive candidiasis. And the bottom line is, in these patients and these mice who are CARD9 deficient, they did not form immunoglobulins in response to the gut microbiota, in response to the candida in the gut. And when these patients then got an invasive candida infection, they got a disseminated and serious infection in comparison to those who were CARD9 sufficient. So again, this could be a very useful marker going forward in trying to identify our highest risk group for candidiasis. And again, some other work from Memorial Sloan Kettering looking at how they could predict the patients who were about to develop candidemia by looking at the microbiome and looking at the fungal candida concentrations in the gut and in the stool, and showing this constant increase in concentration until the patient here developed candidemia in the grey bar. So this is again a potential marker for patients at risk for candidiasis, but it's also a potential intervention in the future for predicting and preventing candidiasis. I wanted to talk in the last couple of minutes about diagnostics, because we obviously rely on diagnostics for our direction of antifungal therapy, not only in the preemptive approach, but even if we're using empiric therapy, we still need good diagnostics to know whether to continue it, how long to continue it for, and what we're actually treating. So improving diagnostics is really, I think, going to be a key factor for us in better using the antifungal tools that we have. So I've just put up a little summary here of some of the diagnostic tests. And those in bold are those where there are recent publications in the last several years. The lateral flow device obviously could increase accessibility to galactomannan and to Aspergillus antigens beyond tertiary centres that have laboratories equipped to do this in a timely fashion, as could the urine Aspergillus antigen. And I'm not going to talk about any of these in depth, but I think I just point them out to highlight that there is work going on in trying to develop the tools that we need to improve our use of antifungals. Of course, the Mucorales PCR assays are very interesting, but have only been used in a small number of centres and not widely evaluated. This would be a great tool for these breakthrough infections where we're not sure what we're treating and whether we're treating Aspergillus or another mould. And of course, the work that's beginning on metagenomic sequencing of blood and body fluids, such as bronchoalveolar lavage fluids, to rapidly identify fungal genes in the tissues and fluids is also, I think, quite promising. And in the imaging arena, the PET scan is something that we're using more frequently because of its metabolic activity. So that when you see a pulmonary infiltrate or a fungal or a nodule, you're able to look at the activity and the metabolic activity, which is often helpful in distinguishing scarring in the lung, fibrosis, and active fungal infection. It can be used to follow infection on treatment. So these, I think, are all things that we are coming along in the future that will help us determine how to use our antifungals better. So in conclusion, I think that we can say prophylaxis, empiric therapy and preemptive therapy, the jury's out. I don't think one is superior to the other because the tools we've got in employing these approaches are quite blunt. And as we can see from the studies that I've shown you, it's often not an exclusive approach. There's often an azole prophylaxis plus an empiric approach, a fluconazole prophylaxis plus a preemptive approach. Early reports do suggest that there's no mortality difference between the empiric and preemptive therapy, but this will probably depend on also the diagnosis and the type of patients. And I think we need more detail from this very interesting European study. An empiric approach may be less useful in patients receiving immunotherapy than in the classic febrile neutropenia population. Less antifungal use has been shown with the diagnostic-driven or preemptive approach, and lower cost as well. But again, this very much depends on your local access and your local availability. So future research on risk prediction for fungal disease, microbiome modification may help prevent infection, and enhancement of diagnostics will improve availability and help identify breakthrough infections with non-aspergillus molds and better guide therapy. So I hope I've sort of summarised the field somewhat and some of the dilemmas that the clinician faces in knowing which is the best pathway to follow here in the antifungal arena. Thank you.
Thank you, Monica, for an outstanding review. I think maybe what you didn't highlight is just the differences in availability and usage of some of the diagnostics and what drives empiric and preemptive antifungal therapy in the U.S. compared to other regions. So, for instance, I mean, I think we are much more empirically driven. Much less reliant on diagnostic tests. I don't quite understand why that is. I don't know if you have any insights into that or not, but I know the Europeans and probably you in Australia are more dependent on the fungal diagnostics than we are. Maybe they are more reliable, or you've just been brought up in a manner to trust these. Do you have any explanation for that?
I think there's a number of points there, Peter. I think, yes, the fungal diagnostics are very much relied on in our setting in Australia, but that comes with a caveat, and there really needs to be the expertise to interpret them. As we've heard from the excellent talk by Dr. Dodds-Ashley, if you can't use these tests in an area where you don't have an expert actually looking at the results, because they're not a black and white test, and you need to take into account, is it a true positive? Is it a false positive? Do I have a repeat positive? Do I have other supporting evidence with CT and PCR? So it's actually quite a process, as you say, using these tests. And that doesn't even account for whether the laboratory is set up to do a quick turnaround time. We are fortunate now in our laboratories in many of the tertiary centres can run these tests twice a week, the galactomannan and the PCR. But you really need that in order to take on this approach. I would say that empiric therapy is a very blunt tool, and my concerns about using it are that you actually don't know what you're treating and you don't know how long to treat it for, and it becomes with successive cycles of chemotherapy, it becomes standard therapy to continue it, so for very long periods sometimes. So I think from an intellectual perspective, it is better to know what you're treating, and you will reduce your use of empiric therapy. All the studies have shown that you will reduce your use of empiric therapy, but the flip side is you will diagnose more infections and be treating more probable fungal infections. So I'm not sure why the culture is different in the US. It's an interesting question.
I've never quite understood it, but it is the world in which we live. I'm going to thank you again. That was outstanding, and thanks for getting up early to join us.